Right, great time to start coughing. Vaping's 98% safer in the context of smoking. You know that, don't you?
I didn't, but I don't smoke anymore, so gave that up a long time ago.
Yay! Yay! You walk the talk. Hey, I've got Andrew Austin with me, and off camera, he's been giving me some great stuff, which I'm not sharing with anybody, Andy, frankly.
Yeah, keep
That,
it
that
keep it
that's
secret.
between me and you. Yeah, that's for Discordian popes only. So, last interview, best viewing figures that I've ever had. I think over 158 people and comments and all that kind of stuff. And I've had personal emails from birth workers who have said that was really valuable to me, particularly a couple that were moving to a new area. And you'd mentioned putting stuff on signposts and all the rest of it. So thanks for that. Today, we are going to focus on EMDR, eye movement desensitization. What's the R? I don't know.
Reprocessing.
Yeah, reprocessing, and then your. It's not a version of EMDR. It's
Well, it depends who
completely
you
different.
ask.
Yeah, I know. I've seen your video.
There's experts out there that know more about it than I do.
I know. I know. They're the same with everything, isn't it? Bit of background though, Andrew. My brother's called Andrew, and if I call him Andy, he slaps me. So I'll probably call you Andrew by habit. Anyway, so in the UK, we have something called the maternal inquiry into the inquiry into maternal deaths. So the highest cause of death at a year amongst pregnant women is suicide post mental health issues. That's staggering, right? Another fact for you: I was talking to a Oxford psychologist on the podcast the other day. Third of women in the UK, as we sit here now, describe their birth as traumatic. Now, 4 years ago, the Birth Trauma Association said the figure was 200,000 women a year describe and label their birth experience as traumatic. It's a scandal, right? 8% of those women will go on to get the full kind of diagnosis of PTSD or complex PTSD, which is a compassionate way of labeling borderline personality disorder. All right. And those that get that label will wait months for either EMDR or trauma focused CBT. So for the last 3 years, I've taken effectively the fast phobia cure and packaged it into a 2-day training that ends up with a scripted process that people can use straight away. When I'm delivering that, I say, this is not therapy and I am not a therapist. This is a guided meditation that when the client follows it, potentially their memory gets re-encoded in such a way that they don't suffer anymore. Blah, 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 blah. Okay. But I intentionally say this is not therapy and I'm not a therapist because inside the systems that I work, the minute you say you're a therapist, people are asking about your BAC accreditation and all that kind of stuff, and you could do more damage and all that kind of stuff. So I want to start off by saying to you, look, I think what I've researched, your what is it? Eye movement into what are the initials?
IEMT, Integral Eye Movement Therapy.
Yeah. Now I get a sense of it, the patterns of chronicity and all that kind of stuff, and I'm really, really interested. But the very first thing I want to say is you unashamedly call it a therapy, and to my knowledge, you might correct me here, you ain't a therapist.
Now, this is, I think, possibly one of the most important questions in therapy that we can have is
Yeah.
what constitutes therapy? What constitutes a therapist?
Yeah.
Now, for many people, it's you've been to university, you've got a degree in psychology, and
Yeah.
then you've done a post-grad, whatever,
Yeah.
or you've done some recognized, approved, university level type course.
Yeah. Accredited. An accredited program.
But then we get down to accredited by whom and recognized by whom, and so
Yeah.
it's a huge problem.
It
Now,
is.
I raise very quickly when this comes up in conversation, how does that qualify someone to be a therapist? because at some point people have to question what is actually going on as therapy, what passes therapy, and is anyone allowed to do anything new? And can anyone do anything new unless they've learned what was previously there formally in a recognized academic institution?
Yeah.
So what I've developed is largely new based on old ideas. And then essentially I started observing things. So am I a therapist? Yes, by function of what I do, not by title of who I am.
Right.
So a lot of people take their job title as an identity. Like, I mean, this is what I rail against. In the alphabet therapy, personal development training world, you get all these trainers. Oh, I'm a trainer.
Yeah.
A trainer is something that people do. It's not a statement of who they are.
True.
Now, as a therapist, I work as a therapist. It's what I do, and I'm delivering change work therapy. Now, people call it change work. They call it guided imagery. It doesn't matter, but let's call it what it really is. Let's stop pretending.
Yeah, but it's easy for you to say,
so
though.
hang on, wait. So I offer that position as a direct challenge. Tell me I'm not a therapist. If there is a criteria by which you can measure therapy. Yeah. Anytime people are giving me a criteria, I can go, okay, I will easily and readily find you 10 examples of individuals who fulfill that criteria, who are blatantly dangerous and have massive consequences on the people they work with. But you're still but those. So are you now saying these are good examples? Because there are so many counterexamples to it.
Yeah.
So all of this notion that basically all these unregistered therapists, they're dangerous. Yes, a lot of them are. I know that. But I've also worked in organized psychiatry, with high-level medically qualified people. And let's talk about some of the things that happen there.
Yeah.
So for me, it's an issue of both definition, plus also, are people merely asking the question in order to discredit or disprove someone they don't like?
Yeah. I mean, that goes on a lot. So broadly within the birth world, the process that I teach, I call it the birthing awareness 3-step process. But it's really the fast forward. It's double disassociation through a guided meditation. That's it. I mean, that's it.
So it's a therapy. Now you can reframe it to be something else to get you off. Basically, to get you off the hook, should you be standing in a courtroom.
Yeah, I do that.
And what I will claim is the majority of therapists and the reframing that goes on to say, well, I'm just a trainer and all this is basically so I can pass myself off as a therapist, but be free of the consequences when it all goes bad. And that's it.
Well, no, I get it. I suppose within the domain that I'm in, so I train a lot of midwives, a lot of antenatal teachers, a lot of doulas, a lot of yoga pregnancy teachers, hypnobirthers. And a lot of those people are offering services to institutions that value NICE guidelines, for example, right? Yeah. And so at the moment, I've got someone I trained who's a consultant midwife. I won't tell you where in the country, but they have a group of trained midwives that have trained in my process. They're seeing hundreds of people supported and helped, right? Suffering being alleviated, people going through the guided meditation, feeling better. And they're in trouble because they're potentially going to get shut down because there isn't an evidence base for what they're offering.
Right. Now, there is an element, though, that's quite important when it comes to registered healthcare professionals. So, as you know, I used to be a nurse as well. Haven't been registered for many years now.
I'm still registered as a midwife.
In order to be a registered nurse and then to be employed as a registered nurse, I'm basically representative of the authorities that run the nursing profession.
The NMC.
So because there's an authority that runs that, and those services are then employed by those individuals into care and nursing hospital type environments, essentially they have to have some kind of demarcation as to, okay, these are the things you can do, and these are the things you don't do and can't do. So there's a very strict criteria. The same with dentists. The same with pretty much any of the registered professions, everything through to accountants, to lawyers, and so forth. Now that's because they have to define the boundaries of the profession, and that makes perfect sense to me.
It does.
So as a nurse, I couldn't then go, I'm a registered nurse, therefore I can do hypnotherapy on the neurosurgical unit. That wouldn't fly, because thinking, well, we don't employ people to be nurses to come and deploy these hypnotherapy type stuff. So it makes sense at some level.
Yeah,
now, when people are fearful for getting in trouble, it's because they're mixing the streams. They're mixing the contexts by which things are delivered.
Yeah.
Now, unfortunately, the consequences of this is that we're all becoming like the call center employee, where we have a single function, single task thing, and anything outside of that, we have to patch them through to somebody else.
Yeah.
And I saw this all the time in the hospital that I worked in. It's like, this is insane.
Yeah.
That I give an example. We had a patient in the neurosurgical department, a female who was in a horrendous injuries. Now, she was in the neurosurgical department. Now, there were two issues, and I won't go in because YouTube will be upset. Yeah. But one of them involved her little finger, and another one involved a lady issue. Now, there was nothing, absolutely nothing about those two issues that no single trained professional on that department couldn't deal with. No. Because it's with first, but no, the finger issue had to be referred to the orthopedic team, and the lady issue had to be referred to the gynecology team, which took days.
Yeah,
it made no sense. But unfortunately, the machinations of the system are now meaning that everyone in the system, because they get caught up in that, they then turn and repeat it.
Yeah.
And the boundaries, the definitions become tighter and tighter and tighter. And so now just seeing a GP for a simple referral can take months, because you have to go to that one for the blood test, then you have to go over across town for the blood pressure test, and they have to go over there for the x-ray. They can't do it all in a one-stop shop.
No.
Now, unfortunately, these professional boundaries and jurisdictions then filter across in the notion of professionalism.
Yeah.
And then it filters out into general populace of people on the peripheries of that system.
Yeah.
And it's madness. And basically everyone's go, well, we'll be in trouble. Well, in trouble with who? In trouble with people just like themselves who are further into the system.
Yeah, no, true.
Crazy.
No, you're right. And it's probably the major reason why I left. I'm older than you. So I remember the nursing process, and then I remember Care Pathways. And Care Pathways was the beginning of the system that we're now talking about. So we've seen the death of the maverick consultant who is doing things left center, because Care Pathways and specialization has kind of killed off general surgery, anything like that.
Right. And what people miss, of course, is one of the major drivers behind that was statistical data collection for government.
Audit, yeah.
Right. And actually, it wasn't about improving patient care. It was about fulfilling requirements of government committee.
Yeah.
And unfortunately, but because we don't realize that, they just get on and do the job they have to do.
Yeah.
It starts to shape the mindset that people have.
Yeah. And just about when I left, the government outsourced the insurance for the health service to an organization called NCT or something like that. So in the end, notes were audited with stickers that you had to tick by non-medical people. And if the sticker wasn't ticked in the right place, you didn't get a certain level of insurance rebate. So it's madness. I'm glad I'm not in it. The only reason I brought it up at the beginning is it's an issue inside the kind of work that I do, and it's why I say that the model I teach is not a therapeutic model. It's a systems model. It's a naturalistic learning model.
Right, but that's just wordplay. Let's be honest.
Of course it is.
Wordplay.
No, it's completely wordplay. It's completely wordplay. Anyway, back to you. I am fairly convinced that what you teach could be used by a birth worker. In fact, you've taught someone I know, Sonia. I can't remember her surname. She used to be a singer. Yeah, that's it.
Richard,
yeah, she's a lovely woman, very skilled.
Many people probably recognize her from the Remembering the 80s books, or any books from sort of glam pop from the 80s.
Yeah.
She seems to feature an awful lot of those. Yeah.
Oh, she's fab. And what she does, I know, is effective in the context of women that label their birth.
Because she has a specialist interest in birthing and basically fertility rights and all the rest, all that goes with that. And of course is highly experienced in the IMT model as well.
Absolutely.
Amongst many others.
Yeah, and I think we need more. I think between us, certainly the work I'm doing, I've trained something like 350 people over the last 3 to 4 years. They go through an accreditation process where they have to do 2 case studies, reflect upon them, and then the case study anonymously feeds back via SurveyMonkey. So they have seen roughly 317 clients give feedback, and it's not audit, it's not research, it's not science. But what I can say is that 100% of those that have been through the process register that it's made a difference in some way, and some transformation. Right? I had one woman write, I've had 30 sessions of CBT, I did this, and it's cleared. Right? And I know that what you do will be effective, and the more people we can get do your training, the more women out there. 200,000 a year, there's plenty of them, right?
Yeah.
So let's first of all clear up the first thing. EMDR and trauma focused CBT is currently recommended by the NICE guideline.
Yes.
Although recent papers have cast some doubt on that. I don't know if you've read any of that. So apparently, when compared with psychodynamic approaches, CBT and EMDR has a shorter lifespan in terms of effect, according to some papers. But anyway, that aside, I saw a video where you're being very vociferous. I mean, that's your way, right? Anyway, about EMDR being different to what you do.
They're not the same models. No.
Yeah, but what? So I know you're not an expert in EMDR. What confuses people, I think, is the fact that EMDR involves, holding the experience current and then moving your eyes to different quadrants or whatever, and that's part of your process, isn't it?
It is, but that's not the totality of EMDR, and it's only a small portion of IMT.
Okay.
Here's what I say.
Go on.
Now, just as an aside, there's a lot of noise coming from your microphone. I don't know if you're rubbing against it.
Good.
Just thought
Sorry.
I mentioned it.
Yeah. No.
Right. So
I'm
EMDR.
getting far too animated and knocking it.
So I know it well. EMDR has a particular model, which is it's more than just hold image, move eyes, but that is the basis of it. It's also the basis of IMT.
Yeah.
What I fairly flippantly say to people when they go, "What is the difference? Aren't they the same?" I go, "Yeah, they are. They're identical, absolutely identical. In the same way that Freudian psychoanalysis and Richard Bandler's NLP are absolutely identical because they both use words.
Words, yeah.
Just because two models use eye movements as the basis of something doesn't necessarily mean they're the same model.
No.
But from a superficial point of view, where people don't, let's face it, you've met therapists. Most of them don't actually know what they're doing. They understand, they know the script to follow.
Yeah.
They know what to do because they have followed the training material. But do they actually understand the qualitative interaction between the two parties?
No,
most of them don't.
They don't have any way of calibrating what's going on.
No, they're just going through the motions.
Yeah.
What they're doing is they're using the standard diagnosis, prescription, treatment model of medicine, which is this. What is the diagnosis? What is the prescribed treatment? Deliver treatment and hope it works. If it doesn't work, try something else. They're not actually able to understand the structuring of human experience, the structuring of problems, and the structuring of interventions and picking the right intervention for the right structuring of problem.
Yeah.
And most people, especially the NLPers who are bad at this, there's no excuse for them, that they're not modeling out what is the structure of the problem, what is the structure of my intervention, do they match? If no, pick a new structure or develop one in the moment.
Yeah.
What people have is a set number of patterns that they, having diagnosed, they then prescribe and deliver, irrespective of actually what's really going on for the individual.
Yeah.
So this is the problem. So when they see two models that seem to use eye movements, the assumption is they've got to be the same. And to what I say to people is, yeah, if you want to think that. And then they say, so what is the difference between EMDR and IMT? And I go, well, have you trained in EMDR? They go, no. Have you trained in IMT? No. Okay, so I'm going to have to now teach you the whole of EMDR.
Yeah.
And then teach the whole of IMT, and then I can tell you what the differences are.
Yeah, no, I understand that.
because it's like taking two completely unrelated things and going, what's the difference between those unrelated things? Well,
Yeah.
they're not the same.
Yeah.
Where do you want me to begin?
I got it. Maybe it's the labeling of it. Maybe I know you came up with the name of your process.
Well,
Yeah,
now I've
you
got a
probably
confession
got it
here.
wrong.
The name, oh my, if there's one thing I could change in my professional history, it would be I wouldn't have called it integral eye movement therapy.
No.
Unfortunate, but
All
it's
right.
what we've got. And here's the thing, it's what
Go
I
on.
called it because I needed a name for something to go teaching something. I never expected it to become popular. I never thought this was going to catch on. This was just something that I had developed, I found particularly useful, and I was teaching to people. And it just became bigger than I ever expected it to become.
Yeah.
And unfortunately, then all the errors that were built in the early, basic branding of it, for want of a better term,
Yeah.
then were developed into, and it's too late to change now because so many people are practicing it, advertising
Well,
themselves
you've got
accordingly.
an association and everything,
Yeah.
haven't you? And some hefty endorsements. I mean, I've heard Stephen Andreas talking about it and using it, and acknowledging
Well,
you
no,
as a developer.
Steve and Colin Andreas, they developed eye movement integration.
Ah, right.
And this is where a legitimate confusion comes in because of the name, because my fault, not that. So eye movement integration was a model they had based on the same eye movement principle, which
Right.
is a much smaller, neater little model.
Okay.
Essentially, I took that and developed it
Yes.
around what are the 5 patterns of chronicity, which is
Yeah.
something that no other model possesses. Although
No.
give it time, lots of people will suddenly discover these and trademark them and incorporate them into their training, claiming they developed it.
Yeah, of course they will.
But essentially, IMT is different from all other eye movement models because the eye movements are secondary.
Got
Primary
it.
is working with the patterns of chronicity, which keep people stuck inside a problem state.
Yeah. I listened through your videos and I'll link them. You did a series on patterns of chronicity. It was
Yeah.
excellent and really informative. So I know that people will be listening to this, and I want them to come and train with me, obviously.
Obviously,
But
yeah.
but I want them to train with you. So if they were going to access this training at practitioner levels, now I know there are different levels, practitioner, and then more advanced patterning that you teach. How long is it going to take them to train? Is it a 2 day, 3 day?
It varies. Now, there's a number of. I mean, we've got quite a lot of trainers for the association, and we've got some very, very good, very competent trainers. Now, people have got lots of different ways that the training is packaged. So typically, pre-COVID, it would be a 2-day workshop.
Right, got it.
And it's two pretty full days, to be honest. Here's what I can tell everybody: there's nothing in the workshop that anyone will go, "Yeah, I knew that." Literally, you've got 2 days of completely new material.
Yeah.
Even if you've done EMDR, even if you're trained in eye movement integration or any other eye movement model, I can be very, very certain everything will be new material. Even the most experienced NLP and trainer will find this new material. So typically it's 2 days, but of course, more and more courses are being delivered online because of COVID restrictions. And so people are either doing it in 4 half days. I'm currently doing one at the moment, which is in 8 2-hour sections.
Right.
But essentially, it's the equivalent of 2 days training divided up.
Let's imagine it's pre-COVID. Are you going to go back to doing 2 days, or are you like
me? I don't like doing courses online. I much prefer the physicality, because the work has a lot of physical interaction between the two parties. It's much easier to do in real life than it is to do remotely.
The whole calibration process is facilitated by being with someone, and we're herd animals, aren't we? So anyway, so let's imagine pre-COVID days then, Andrew. What are the themes then that you cover in the training? I just want to give people a taste of it, obviously without.
Okay, there's a number of core principles. One of which is the whole thing is trying to solve the question: when people feel bad, why do they feel the way they feel? And when people don't like themselves, because problems are either at an emotional level, I feel bad, and an identity level, I hate myself.
Yeah.
Another example would be I feel depressed versus I'm a depressive.
Yeah.
One's an identity, one's a kinesthetic emotional reporting.
Got it.
So essentially, the day one is all about the emotional stuff. Day two is all about the identity stuff.
Wow.
And they're actually substantially different days as well in terms of what we are doing with those issues.
Right.
The other thing that is the prominent theme is the patterns of chronicity. Now, these are 5 distinct behavioral patterns that are not causative of the problem. They're secondary to the problem. So people don't have the problems they have because of these patterns of chronicity. But for many people, the problems are resistant to change, time being the number one thing. Most problems wait long enough, they get better. Most of them do.
True.
But not everything does. And so sometimes some problems are resistant to all forms of change, whether it's therapeutic, even if there's a skilled therapist, as well as time, medication, and all the rest. So these 5 patterns are emergent from suffering. They're not necessarily the cause of suffering, but they lock in the suffering because let me give an easy example of this. This is not a pattern of chronicity, but it is specific to depression. Getting somebody who's hopelessly depressed to be motivated to do something about it. It's like, because they're too depressed to do something about it. It's like when you're really, really bored and someone gives you something to do, you don't want to do it.
Yeah.
Because the very condition itself insulates itself against change.
Yeah.
Right. The patterns of chronicity are the universal patterns that tend to affect people. And so these are the things that we then teach how to address those patterns. Now, by effectively addressing those, you remove the inbuilt defenses that the problem has. Most of the problems will get better on their own.
Right.
Not all, but many of them will. And then for those that don't necessarily do so, we then have direct interventions that we can use.
Right. And the eye movement thing is part of the intervention.
Yeah, part of it.
Right. Not the only bit.
Nope. There's lots. There's all sorts of little details in there as well.
Got it.
Now, unfortunately, too many practitioners who've done the training, they just end up waving their finger in front of somebody else's face, telling them to move their eyes.
Yeah.
And because unfortunately, I do my best. I do my best to make therapists more clever than they actually are, and I'm unashamedly critical of therapists, even though I'm technically not one. But I've been very critical because so many of the subtleties that would actually make them superb at what they do get dropped. Yeah. And they just end up doing basics from what they can remember, not actually truly understanding what it is they're doing. They're just remembering what to do.
Yeah. Do you know,
there's a difference between understanding what to do and understanding what we're doing and just remembering what to do.
No, I get that. It's one of the reasons the process that I do is scripted initially. So the principles are embedded in the script over 3 sessions. But no, I get that totally. So quite a lot of your focus early on is getting the student to be able to know which pattern is manifesting here.
Yeah, in part, what I do as a trainer, and I know some of the other trainers do as well, but it does depend on people's personalities and sort of levels of experience, really, is I'm constantly provoking these patterns of chronicity in the audience.
Yeah.
And sooner or later, people start demonstrating them, usually in the form of their questions or behaviorally within the group. And in which case, that gives me the perfect opportunity then to work with that pattern.
Yeah.
And so that's one of the things I build into the trainings that I do.
That's brilliant. So once someone has been through your initial training, are they accredited as a practitioner at that point, and do they?
Now we're back to the old accredited by whom and recognized by whom.
Yeah, I know.
Yes, they get a genuine certificate with my signature on it.
I know, but people ask
and they're fully recognized and accredited once they've passed assessment by the Association for MT Practitioners.
Yeah, got it.
Which sounds good.
Yeah,
but I say it like it is. I mean, there's all these organizations giving accreditation and recognition. Most of them are just something somebody made up as a cash cow. Well, now, the association is just something I made up as a cash cow.
Yeah.
Now, it's become bigger than that because what I'm trying to do is get this thing formally recognized. I'm trying to get formal recognition of the work that is taught and of the certificate issued. We're not there yet. No. So we've got to be realistic. Is it worth anything? Probably not.
No, but it is. But it is a way to build in some kind of quality insurance for people that are going.
I claim that. I would claim that, and I do claim that. However, I'm also realistic because you can compare me to things like what the ANLP,
Yeah.
the Association for NLP, which is a self-appointed body of people who are the
Yeah.
Association for NLP in the UK,
Yeah.
and they give accreditation to courses of, and they didn't even. I mean, God, you won't see the developers, any of the developers of NLP on the board or actually part of ANLP at all, but they give awards.
Yeah, I know.
So
Well,
is the Association for IMT Practitioners
yeah, and
any
there is
superior to that?
no.
No, it's actually at exactly the same level as all those other organizations, boards, panels, and everything
Yeah.
else. However, what I'm trying to do is get it to that higher level effectively.
Yeah, where
But that
practitioners are held
brings in,
accountable to a code of practice and stuff like
right,
that.
but then here's what I got to be realistic. So I get this thing accredited where it's recognized by government, it's recognized by medical authorities, and it's recognized by as a university level at, you know, basically it's the equivalent to GCSE or whatever. It's a formal qualification.
Yeah.
Now I'm straight into this jurisdiction boundaries and professional standards, which
Yeah.
is the very thing that I rail against within organized healthcare because of all the problems it brings in. So whilst ostensibly getting recognition and formal accreditation is a good thing, I'm well aware it's also counterproductive at the same time.
Yeah, it's a double-edged sword.
It is.
For sure. The only reason I went down the pseudo accreditation path was because people were asking me. And one of the other training organisations had got the RCM, the Royal College of Midwives, and they say it's accredited by the Royal College of Midwives. But I could get that. I just have to pay £1,800 a year.
Yes.
And fill out a few forms.
Let's face it, they have homeopathy courses that are fully accredited.
Yeah. Yeah, it's mad.
The NHS used to have a homeopathic hospital that taxpayers would pay for little bottles of magic water and what amounts to little more than faith healing. And yet that was fully approved and accredited.
Yeah. Yeah, it's mad.
We had the Bristol Cancer Clinic, which was using guided visualization where people would imagine the cancer cells being eaten away. So this is a problem. It's such a minefield, but what my experience is, the majority of clinicians and the majority of the public do not understand the implications of it. And people think if we can bring in some form of regulation, then that improves things. It doesn't. No. It legitimizes the arseholes. That's what it does.
Yeah, and it encourages unthinking, unreflective type practice because people are just following, inverted commas, a guideline.
Yeah.
Yeah.
So it's a huge area. I say that is worthy of debate, but it's not of interest to the majority of people who don't really wish to understand or who look at the intricacies involved.
Yeah, who don't care. I mean, the only rigor in my accreditation is the reflective case study and the feedback from clients. And what I did was I negotiated with an insurance company so that the insurance company can get paid an insurance premium and they accept a practitioner certificate. But that's a scam as well. I mean, I wonder how many claims there have been in the last 5 years.
I worked with somebody this morning who was being paid, basically the sessions being paid for by the insurance company. And yeah, I know I could milk that. If I was so motivated, I could keep that going for as long as I wanted to.
Yeah.
But ultimately what they're looking at doing is reducing the compensation payout to the victim. And so by having me on board to do that therapy, I get paid, and it basically comes off the reduction in the payout to the victim.
Yeah.
So it's so much of these things that go on. It's just astonishing to me. But people don't know. People don't realize.
No. So let's get back to these 200,000 women a year that are giving birth, not to mention their partners, by the way. Because there's a growing number of cis heterosexual partners, men, that, like we used to call them. there's a growing number of men that are suffering after being at a birth, experience. This process would be helpful for them. Yeah, without no doubt.
Well, I don't know. I haven't met them yet.
No, I know.
But this is a problem. Is as soon as we want to build in a generalization that says yes, this methodology is suitable for this category of person, but realistically, it then comes down to an effective practitioner doing effective and realistic assessment on a particular individual, and basically calculating what is the best possible approach to use that for that individual.
Yeah.
However, if I'm drawn to backed into a corner to have to give a generalization, will traumatized people find aspects of IEMT effective or beneficial? Most likely. IEMT itself has built into the model a distinct pattern, and it's a very, very distinct pattern. It's unique to IEMT for working with people with traumatic related issues. And it's something that, as I say, it's unique. You won't find this in EMDR or any other model. Although give it time, it will be absorbed and assimilated into the other models. I know it will.
Yeah, without acknowledgement, probably.
I've got to be honest, the acknowledgement thing. Otherwise, we'd never be able to have a normal conversation without constantly referencing every possible development along the way. I accept it as inevitable. Really.
Yeah, I mean, you're quite open about the fact that I think you said not Charles Faulkner, someone's work with pronouns affected.
Oh, that's based on David Grove's work.
Yeah.
So there's a huge in the identity module of IEMT, David Grove's work around pronouns, which was later also developed by James Lawley and Penny Tompkins of Clean Language fame, which is a model I highly recommend people have a look at or go and train in. Also, another way of working with trauma, completely unrelated, but very, very good. There was an aspect from Grove's work that I've incorporated into the identity work.
Yeah, and some of Charles Faulkner's stuff.
Here's an influence on IEMT, but not directly so. Okay. On the Integral Eye Movement Therapy.com website, on the first page there, I've got some infographics which give you all the background influences and core concepts, which people may want to have a look at.
Yeah, cool. I interviewed Caitlin Walker on symbolic modeling. Again, I think that's influenced by David Grove.
Yeah, it's another Grovian derivative. Absolutely.
Yeah. So let's end, because we've been talking 40 minutes and I'm having a great time. Thanks for being on. Let's focus now then. If you were a birth worker, let's say you're a birth worker who isn't subject to any Royal College, and they're getting a constant stream of clients who are telling them that they're suffering after a birth experience. Given all that's out there, what would your kind of recommendation be? I mean, obviously it's going to be come and train with you.
Well, obviously, always need the work.
Yeah.
I've got to be realistic. For the Association of IEMT Practitioners, we have quite a list of trainers, and if people go to the website, they'll see the different courses that are being offered by trainers. Always bear in mind that the training list is updated constantly as trainers announce new dates. So if there's nothing on there that people see, oh, that's the one I want to do, just check back in a week or two and just keep checking back, because there's always new dates going up. Because we've got like at the moment probably about a dozen active trainers, but there's a lot more who, once COVID restrictions are lifted, they'll be teaching again as well.
Yeah.
And we have trainers pretty much throughout Europe, in Asia as well. We've got people in Rochester as well, in New York, USA. So there is lots of scope and opportunity for people to do the training course. Now, with myself as well, I've just got to emphasize that each trainer brings their own particular expertise. Now, whilst I'm the creator and the developer of the model, I don't have the experiences or the expertise of the other trainers that they have. And so the courses, whilst the core material is the same, the sort of the angle, application, and flavor of it will be different for different trainers. And so that's something that people ought to consider and bear in mind. And if they want to train in a particular area with particular application, then just get in touch and I will refer them to the appropriate trainer.
Brilliant. And we've already mentioned Sonia.
Yeah, who does obviously hypnobirthing. It's one of her background specialties, really, for one of a better term.
Yeah. And when someone has done the 2-day training, I'm assuming that they will all follow a similar format in terms of structure.
Yeah, in theory, yes, they should.
Yeah.
We are in the process of enacting again, it goes against everything I stand for. We're enacting standardization. So we want the courses to be largely identical in the IMT content.
Yeah.
But of course, many of the trainers will introduce additional content depending on the angle that they're
Yeah.
coming at the thing with.
Yeah. But I understand the need for standardization. Do different trainers charge different amounts?
Yes, we don't have a standardized because different environments require different fees.
Yeah.
For example, someone in London is going to be hiring a very expensive venue compared
Yeah.
to someone where I am, for
Yeah.
example, half the price. So
Yeah.
yeah, so there isn't a standardized price.
No. But
You're
is
looking
there a sort of like a
around,
mean? Could
yeah,
you
you're
give us?
looking £300 to
That's
£400
good. That's good for
for the
two
training.
days.
Maybe more, maybe less.
Yeah. And after someone has done it, will they be able to start working with someone straight away?
No,
No. Oh, well, that's honest.
absolutely not.
Well, that's
Now,
honest.
there is some criteria. Now we encourage people to start practicing and experimenting, but hopefully not with paying clients.
Got it.
In order to get a certificate, there are two things they have to do. They have to pass assessment, and the assessment, we need a video of them working with people.
Oh, that's brilliant.
Which, as you can imagine, a lot of people go, I'm not doing that. Well, fine, you don't get a
Yeah, but
certificate.
that's brilliant.
And a couple of case studies to write up as well. Now, what we're
Brilliant.
testing for is not that they can deliver this in an efficacious manner, because it's not about the outcome. It's like, do they know what they're doing?
Yeah.
Now, once they have passed the criteria, they then are required to join the Association for IMT Practitioners,
Yeah.
where there is a whole host of post-qualification, post-certification training material.
Fantastic.
And ongoing, a constant update of stuff.
They get access to that for the price of the
No.
training itself.
No, it's £50 a year. So we keep the cost low. Yeah. And within that, we've currently got a whole load of guest speakers. Pretty much every 2 months, we have an academic speaker. So we've just had Mr. Felsted from the British Forced Memory Society doing a talk on issues of recovered memory therapy. We've got a professor of nursing as our next speaker talking about other issues around things like Munchausen's and killer therapists. So we've got all sorts of quite interesting and out there subject matter, and that's now going to be a rolling program.
Wow.
For people, and that's free for all members.
Wow, that sounds like 50 quid well spent.
I think it's absolute bargain, to be honest, for what people get. Plus, there is a huge archive of video training material as well for people to get into.
Yeah.
Now, you don't have to do a training course to access that material. You can join as an associate member, which basically means you're an uncertified member of the association, and it's the same price. And when people do a training course and want to upgrade, then it's free upgrade.
Brilliant. So, someone choosing this track or this path, they're getting ongoing CPD built in at a really reasonable price.
Yes.
And potentially in the area of birth, a massive client base.
I think so. I think there's the potential if people are willing to put the work in, and this is again something I'm known for in my criticisms of therapists. Work harder. It's not much to ask. Put some effort in, because here's the deal. You and I both know the waiting list for people to access mental health services is phenomenally horrible.
Yeah.
The efficacy of mental health services is pretty poor, and the services predominantly because of the nature of what they do, but also because the services are so overwhelmed. It's very hard for people manning these services to actually run it effectively because the lack of staffing, lack of funding, and an overwhelm of uptake. And this is an area that I think people really ought to be paying more attention to, as to basically put the work in to study the skills, get the relevant experience, but also then to market themselves effectively to actually say what they're doing. And if you're working as a therapist, call it like it is.
Yeah, I get that. I need to think about it.
I'm one of the few. What I say to people when I'm asked, so where did you do your degree then, Mr. Austin? I always say to people, you do know I'm the lowest qualified person in this room right now, don't you? Just saying. And if you think I went to university, you really, really got a misunderstanding of who I am. Just shut that one down right there and right then. But do you know what? It makes because of what I've developed and what I teach, I'm invited pretty much internationally. I do a lot of traveling. Well, again, pre-COVID, a lot of traveling for teaching, but I don't have any issue with doctors. There's no doctors make referrals to me on a fairly regular basis.
Yeah.
And it's not an issue.
No.
It's not the issue that everyone seems to think it
I
is, and
think
people keep telling me it is.
I think it's invented by people like me.
Could be.
Yeah.
I also suspect it's a way of therapists or coaches, because let's face it, who wants to be a therapist or coach? It's somebody who wants to give up the day job and get paid handsomely for having a conversation. I'm going to get paid for sitting around having a chat, and in case it goes wrong, I'm fully insured. Only therapists can get a conversation so bad they've got to have insurance for it. I mean, really, what on earth is going on here?
Yeah.
And so for a lot of people, this the medical world is very closed. The doctors are closed-minded is actually a pre-made excuse that they have, because the one thing I know is that wherever I have worked, everyone is extremely open-minded and very open to these things. And is the only people I find are closed-minded are alphabet therapists who are closed-minded about the medical professions, closed-mindedness or open-mindedness, whatever that thing is.
I get that. I get that. Thanks, Andrew, for coming on again.
Oh, my pleasure.
That was fantastic. Now, are you still reading the same 2 books, or have you got another recommendation? Last time it was Steps to an Ecology of Mind.
Oh, no.
No. It was not this book, but it was by him.
Paul Václavic. I get everything by Paul Václavic.
Yeah, no, agreed.
Currently working on...
Go on.
This might seem familiar. Callista Roy.
No, I don't know that.
So this is Callista Roy, Sister Callista Roy, the Roy adaptation model.
Right.
Anyone who's learning IMT needs to get this book. Now, even though this book is about nursing,
right,
and it's a core nursing model, Callista Roy, I think, is one of the unsung heroes and geniuses of human potential, human behavior.
Right, just writing it down.
Callista Roy adaptation model.
Brilliant.
Now, she is a nursing sister, a nun, nursing sister, and now professor of nursing, and I think professor of philosophy.
Is it a nursing model in the same way as 12 Activities of Daily Living?
Orum's model.
And Orum and all that.
Right. So, now, I've got it here somewhere. Here, I've got Dorothea's book as well, which I'm reading, Dorothea Orum's book.
Right.
Now, essentially, this could be a handbook for IMT.
Really?
Simply because of Roy's vision for the delivery of care to facilitate the person functioning in life
in a holistic sense.
Oh my goodness, how did I never know this before?
I never heard of that.
I know. This is absolutely where it's at. Now, this is the model that in some rehabilitation centers, this is the most popular model that you'll see.
Really?
And it's essentially, how do people adapt to society? How do they adapt to health challenges? How do they adapt to change? And that our role as people workers in whatever form, whether we're a nurse, doctor, whatever, is to facilitate people's adaptation to their own life.
Yeah.
It's the opposite. This is the exact opposite to the total care model, as of like in Irving Goffman's work of the book Asylums, which is the total care institutionalization model, which, you know, I understand why that is useful in some contexts. This is the antithesis of that. And this is absolutely where it's at for me.
Wow.
Callista Roy is my new hero.
Well, I'm going to get into that. I mean, I remember getting really stirred up by Peplau and his model when I did mental health nursing. Yeah. You know, as my segment.
She doesn't know it yet, but I'm going to try and get Callista Roy to give a presentation to the association.
Oh, she's still alive?
Just. Well, I say just. Right. I mean, that sounds awful, doesn't it?
Get to record it.
I hope she's not watching this. Callista, you're a hero of mine. No, I think she's probably got to be in her 90s now.
Wow.
She's knocking on a bit, but by the look of things, she's still going. So I'm going to ask her.
Great recommendation. And are you a series watcher or a film watcher?
Both of those, yep.
All right, come on, give us a series.
Of what?
Something you'd recommend people watch.
What, is related to what we've been talking about?
No, just you as a human being.
I think my absolute favorite at the moment, which I think many of your client group may appreciate if they haven't already seen it, is called Motherland. It's a
I've,
BBC production. It's both on Netflix and it's on the BBC iPlayer,
I've
Motherland.
heard of it.
I've got to be honest, I think it's one of the funniest things I've ever seen.
Motherland. I'll check that out.
It's got three seasons, and it's really unusual in that most comedy series, they don't get better as they go along.
Motherland. Okay.
This one gets better with every episode, and the third season is by far the superior. It just keeps getting better.
All right.
Allegedly, they're making a fourth as well, which I really do hope for.
All right. And one last thing, a film recommendation.
Oh God, where do we even begin with that?
Something that you watched that comes to top of mind.
Well, the one that immediately comes to mind, because it's one of my all-time favorite films. Actually, I've got two. Forrest Gump.
Really?
So, absolutely, I think it's one of the best films ever made. But the other one, which is the film I've seen more than any other film, is The Man Who Fell to Earth.
Oh,
The book
David Bowie.
The book is phenomenal, but the film is absolutely incredible.
That is David Bowie, right?
It is. Top tip for you, for those who've seen it, watch it again, but actually watch it from a different angle. He's not an alien at all. He's actually psychotic.
Wow, you heard it here.
And if you watch it from that
I've
angle,
not seen it.
actually,
I'm going to watch
the
it.
film shows actually he's very clearly a psychiatric patient. Very clearly.
Wow, I've not watched it. I've not watched Forrest Gump through, and I've never watched The Man.
My goodness,
I'm going to do it. I'm going to do it. Andrew, thanks being so generous with your time.
Oh, my pleasure. Thank you.
I'm going to make up something so that we can talk again.
Yeah.
Thank you very much.
How to market yourself on YouTube might be a
good... I think
maybe
go
through that with you.
Yay. Thanks for listening, everyone. We're done now. Bye.